Hi everybody. My name's Wendy. I'm the GP Liaison Officer here at Northshore Private. I also help out with promoting our maternity services here at Northshore Private Hospital. We're really excited to welcome you to our Getting Ready for Pregnancy webinar that we're holding this evening. We hope you receive some really useful information about lifestyle, medical conditions, genetic screening, pregnancy, bringing your baby home, and our maternity services here at Northshore Private Hospital. Some housekeeping items for the session. We've muted everybody and made it a webinar, and that's just purely because we're going to have a large number of participants on here tonight and we don't want any distractions, but we'd like to make the session interactive. So if you have a question for one of our speakers, please feel free to use the chat function or use the Q&A button on your device. The chat and the Q&A can be accessed on the bottom of your screen. I'll interrupt our speakers periodically and ask questions on your behalf. If we have a lot of questions, we may not have time to answer them all tonight, but please feel free to keep on asking them via the chat, via the Q&A, or email us in any questions and we'll endeavour to answer those over the next few days. Our maternity bookings officer, Emma, will also be in touch in the next couple of days with your Bugaboo voucher as a thank you for joining us tonight. And she'll also be able to answer any questions you have about booking at Northshore Private Hospital. As you know, we have three speakers this evening. One of our very experienced obstetricians, Dr. Michael Vandergrund, who will present first, then one of our mothercraft nurses, Chris Minogue, and finally, Stephanie Begona, our Clinical Services Manager of Maternity. So I'm going to hand over now to Michael to start his presentation. I'm going to have to ask you to unmute yourself, Michael. Can you do that?
Unmute.
You've got it. Well done.
All right. Okay. Thanks, Wendy. Thanks, everybody, for joining us on this evening and giving your time away. Now, look, this will not be an exhaustive exercise. Wendy, could you just come in and just help me get started with the slides? Look, one of the first things I'd recommend to all couples who are contemplating a pregnancy will be, if you've got time, touch base with your GP. It's always good to just get some of the things we're going to cover out of the way because they're a good pit stop and they'll offer you similar advice to what I will be suggesting as well once we get started. I escaped and then we did. Sorry guys, just a bit of a, I think it should be right now. Seems to freeze. Okay, there we go. There we go. We're good? Good to go. Excellent. Just a little hitch. So as Wendy said, I'm one of the obstetricians here at Northshore Private Hospital. I'm currently the head of the department. I've been at the hospital since its inception in 1998. Great place to work and really good staff to work with. Highly recommend the hospital as your point of stay when you are in fact pregnant. This evening's presentation, we'll talk about lifestyle, general medical conditions that can impact on a pregnancy, supplements, genetic screening, and the benefits of being privately insured. So the first graph, and look, a lot of you will have heard this previously, talks about the relationship of age and fertility. So the take-home message from this slide is don't wait too long. And I know that's not always practical. Sometimes you haven't met the right partner at the right time, but you can see that fertility does decline quite dramatically as you hit your mid-30s and beyond. And the other thing to think about too, I'm not going to bang on about fertility here because that's another scope to talk about, but one of the things that does happen as a woman ages is not just fertility declines, but her risk of miscarriage increases. And one of the big drivers for that is the risk of increased chromosomal problems like Down syndrome. So once you're hitting 40, your risk of having a baby with Down syndrome is about 1%, if not a little bit higher. So don't wait too long. So lifestyle changes, look, before you get pregnant, it's great if you can maintain an optimal weight. You don't want to be at the extreme ends of the spectrum. If you start your pregnancy 10, 15 kilos overweight, one, it's going to be an increased weight to carry during the pregnancy, but two, you're going to increase your risk of getting gestational diabetes later in the pregnancy and probably making delivery a little bit more difficult itself. So ideal weight's great. you don't want to be right down the very bottom end of the spectrum. And if you maintain a very low weight gain during pregnancy and you start underweight, that can sometimes be associated with growth restriction in your pregnancy. So weight's a good factor just to try to work on. Don't be obsessive about it, but just try to be in the middle of the range if you can. If you're contemplating a pregnancy and you're smashing the cafe lattes and the alcohol, one thing I would recommend as you think about going off the pill or your regular form of contraception, maybe start to reduce alcohol consumption, caffeine consumption, because you don't want to go cold turkey as soon as you know you're pregnant. Wean yourself off. And I suppose that also matters if you're in the late stages of your cycle and you could be potentially pregnant, but you're going to go on a blinder, maybe just wind it back just that little bit. That certainly helps. But if you could cease cigarette smoking altogether prior to the pregnancy, it's going to be so much easier when in fact you are pregnant. And I'm not sure how many people out there are partakers of recreational drugs. I live in the eastern suburbs and it seems to be one of the hot spots of Sydney if you're checking sewerage outlets. But things like cocaine, which are used quite commonly, do have an adverse effect early in pregnancy, increased risk of miscarriage. So same again, if you are potentially pregnant, try to stop it altogether. So another thing to contemplate are women who have coexisting medical conditions, things like diabetes, epilepsy or thyroid disorders. So if you're a diabetic, and especially a woman who's an insulin-dependent diabetic, you want your control as good as possible around the time of conception. Now, a lot of women will have endocrinologists and a lot of women in this category will have insulin pumps, so it's a little bit easy to dial things in. But if your control is excellent around the time of conceptions, that's something to aim for. If it's really poor and you're having really highs and struggling to control, there is a slight increased risk of congenital abnormalities in poorly controlled diabetes around the time of conception. So probably good to touch base with your endocrinologist, get your control really sorted in those early weeks of pregnancy. And the same applies for epilepsy. There are a number of anti-epileptic or anticonvulsant medications out there that are relatively contraindicated in pregnancy. So if you can change to one medication that is more optimal in pregnancy, that would be good. Same again, touch base with your neurologist, work out a game plan. If you could go off anticonvulsants altogether, that would be excellent, but not at the expense of having breakthrough seizures. Women who are on anticonvulsants, it's recommended that they have an increased dose of folic acid, but we will talk about supplements just a little bit later. The same applies to thyroid disorders. If you have an underlying thyroid disorder, it's good to have optimum control around the time of conception. If you're profoundly underactive, one, you probably struggle to conceive, but two, it can have some effect on baby's neurological development. So same again, get those things sorted. Another recommendation, if you're due for a smear or almost due for a smear, or certainly if you've had a past history of an abnormality on a cervical pap smear, get one sorted so that if it is abnormal and significantly abnormal, it can be treated prior to being pregnant rather than worrying about it all the way through a pregnancy. I had one of my patients who popped in just for a routine gynecology visit. I said, when was your last smear? Hadn't been for a while. We did one. I rang her back a week later and said she had a significant precancerous change. She said, oh, I'm pregnant. So she didn't even know she was pregnant at the time, but we managed to monitor it throughout pregnancy, but it was just a bit stressful on her part. So it would have been better to have had that sorted prior to the pregnancy. So what about vaccinations? Look, same again, touch base with your GP. If your rubella status or German measles immunity is really poor, it's worthwhile getting revaccinated prior to being pregnancy and probably just leaving it for at least 2, maybe 3 months post-vaccine before you in fact conceive. So good port of call, check rubella immunity. If you are contemplating pregnancy, the influenza vaccine's out, I'd recommend get it, because if you do get pregnant and you come into contact with influenza A, which thank goodness with COVID, we don't seem to be seeing a lot of it now, it's good to have a vaccine on board. You can certainly be vaccinated during pregnancy, but if it becomes available prior to it, I would recommend it. As to COVID vaccine, it's not recommended currently for women who are in fact pregnant unless you've got significant comorbidities. And by that I mean if a woman's got a significant medical illness that is significantly influencing her immunity, and if she got COVID, it would seriously adversely affect her health, we'd recommend COVID vaccination. For the vast majority of women, we don't recommend routine COVID vaccination at this stage because we just don't know about the safety. However, if later this year your number comes up for the vaccine, you're contemplating a pregnancy, get vaccinated. Even if you fall pregnant pretty soon after a COVID vaccine, that appears to be quite safe. So that's something to think about as the vaccine rolls out over the next few months.
Michael, we've had a couple of questions not directly related to the slide. First one is, after how many months, years of trying should you consider medical advice if conception is not happening?
Look, I think that depends on the woman's age. If you're under 35 and time is on your side, I would wait for 12 months because we know that 12 months of actively trying, only 75% of fertile couples will have conceived. So you've got to give it 12 months. However, if you're 40 or in your late 30s, I think you've got to bring the goalposts forward. Don't wait 12 months, maybe at the 6-month mark. If you've been charting your cycle, things seem to be right, your timing, intercourse around ovulation, I'd probably touch base at the 6-month mark. So it really does depend on your age in that category. So if you are older, you've got to be a bit more proactive.
Okay, thanks, Michael. One more question around diet. Is having hot milk tea twice a day, about 200 mils each, okay to have while you're pregnant?
Perfect. Look, once you get pregnant, it's okay to have caffeine, just don't have too much of it. So same again, if you're smashing 6 double cafe lattes a day, that's probably a little bit too much. So too much caffeine in pregnancy, and this goes for the whole of pregnancy, not just early. Caffeine's a constrictor of your blood vessels, so it may have an effect on baby's growth. But 1 or 2 servings of caffeine a day is quite fine. So you don't have to go cold turkey.
Okay, thanks, Michael. That's all the questions for now.
Okay, so supplements. So look, same again, there's a lot of data out there on folic acid supplementation in pregnancy, and it's highly recommended that all pregnant women start a folic acid supplement prior to getting pregnant, if at all possible, and at least take it throughout the first trimester because it will reduce the incidence of neural tube defects, and that involves abnormalities in the baby's spine and abnormalities in the baby's brain. So you need to be on a supplement that has 500 micrograms of folic acid. There's lots of them out there. All of them have different amounts of multivitamins, different amounts of iron, different amounts of iodine. I'm not going to push one over the other, but find one that agrees with you. But one thing to think about with supplements when you are in fact early in the pregnancy is sometimes when you're getting pretty bad morning sickness and nausea and vomiting, it's pretty hard to swallow a big supplement when you're pregnant. And what I would recommend there is if you're struggling a little bit with nausea and vomiting, maybe just change from a general supplement like Elevert or Blackmore's to a straight folic acid supplement. Well, there's one by Blackmore's called Folic, which has got iodine and folate, really small tablet, easy to take. You don't tend to get that aftertaste. So folate, important. Now, don't stress if you suddenly get pregnant, you haven't been on folic acid. If your diet's healthy, you're having lots of green leafy vegetables, you're probably okay with folic acid. But if you can, if you're into your last packet of the pill, right, we're going to start trying next month, start the folate at least a month before you conceive, if at all possible. As I was alluding to earlier, if you are on anticonvulsants, if you do have epilepsy and you're on certain forms of anticonvulsants, I would recommend an increased dose of folic acid to 5 milligrams a day, which is 10 times what we would normally recommend, because folic acid does get adversely metabolized and with anticonvulsants, so you do need a higher dose. And there are other medical conditions which we recommend a higher dose of folic acid, especially some of the clotting disorders. So folate, important. Vitamin D, it's actually quite interesting. I see a lot of women who come in for their first visit who are quite vitamin D deficient. So probably not a bad idea to get your vitamin D checked before you're pregnant. If you are quite low, you don't want to go out in the sun and get melanoma, but you can certainly take a vitamin D supplement. And look, if your periods are pretty heavy, you might find that you're starting pregnancy a little bit iron deficient. So you may want to get your iron stores checked prior to pregnancy, because even with reasonable supplements, they do tend to drift down during pregnancy. So if you can find a supplement that agrees with you, that has a reasonable amount of iron, stick with that as well.
Michael, just one question on supplements. How soon before pregnancy would you ideally start supplements?
So recommendation is a month or more. Look, some women are on it for a year. They're going, oh, look, I think I'm going to get pregnant. I think I'll start trying. And you can't have too much of it because you'll excrete it in your urine. But ideally, a month before conception. But as I said, look, if your diet's pretty healthy, don't stress if you inadvertently got pregnant and you weren't on a supplement. Start it as soon as you find out you are pregnant and continue on it. But yeah, 1 month before is ideal.
Okay, another quick question on food. And then we might skip and let you talk for a while so we don't have too many questions now. What type of outside food cuisines are safe to eat during pregnancy? You know, what if I often don't get time to cook at home?
Yeah, look, just go to takeaway. There are a lot of takeaway places that really do good organic type foods, and I'd probably stick with healthy sort of options out there. Your local Thai is probably not that great. It's got a lot of carbs in it. It's got palm sugar. It's pretty high in carbs. So I just try to find somewhere that's fresh, preferably doesn't have to be organic, but the produce is good and you're happy with where they've got the produce. Look, I'm not going to talk too much about listeriose. Well, I actually aren't, but try to avoid raw foods. So if you're going out having sashimi, you've got to really be sure that it's very fresh. And if you're not sure of that, just avoid raw foods, profoundly undercooked steaks, that sort of thing. So takeaway's fine. Just make sure it's fresh, make sure it's healthy, covers all the main food groups.
Thanks, Michael. I'll let you carry on.
Okay, we'll keep going. So post supplements, one of the things I wanted to talk about was genetic screening. Now, it's something that our college, the RANSCOG, have recommended that all pregnant women have access to. And what this means is not screening for things like Down syndrome so much. That's actually performed when you are in fact pregnant. And as I talked about, look, that risk is higher as you get older. But these are genetic conditions which don't seem to be influenced by age. And the three common ones that our college would recommend couples consider to be screened for are CF, cystic fibrosis, spinal muscular atrophy, and Fragile X. Because if you look at the incidence of these genetic conditions, it's probably similar to the incidence of chromosomal abnormalities like Down syndrome. So something to think about. Great if you can get it done before you're pregnant. You only ever have to do it once because you're either a carrier for one of these conditions or you're not. So you don't have to do it every pregnancy. If you can do it before you're pregnant, good to do. If you don't stress. You can actually do it during your pregnancy, but it's just another test you have to wait a couple of weeks for to get a result. So as I've said, carrier screenings, it's estimated that the general healthy human beings are probably carriers for 2 or 3 rare recessive disorders, but it's the common ones that we're worried about. So the incidence of the carriage for cystic fibrosis in the general population is about 1 in 25 people. So it's pretty common. But with these particular conditions, both parents have to be a carrier. And if you look at that little graph there, on average, if both parents are carrier, there's about a 1 in 4 chance of the baby being affected. There's a 1 in 4 chance of the baby being completely normal. And there's about a 1 in 2 chance of the baby being a carrier, just like the parents. So if, in fact, you do get screened, you have options. You can do one-step screening where both couples go to a pathology lab or a genetic counsellor. I preferentially send it to one of my ultrasound practices. They have a genetic counsellor there. So both couples could get tested at the same time. You're going to find out both results quickly. It is a little bit more expensive because you're getting 2 people screened, but then you know. Or you could do a 2-step option where the mother gets screened, and if the mother is in fact negative, it doesn't matter if the partner is a positive because you're not going to pass 2 genes on. If, however, the mother does come back positive, then the partner will need to be screened as well. It's a little bit less expensive that way, but it does take a longer time to get the results. Now, as I said, this is not absolutely necessary. It is an optional extra. So there'll be couples out there who will say, look, I don't mind if I have a baby with cystic fibrosis or Fragile X. It's not going to change the way I'm going to manage my pregnancy. And if that's your philosophy, you don't have to get screened. But from my point of view, it's just, if you can tick that box before you're pregnant, it's one less thing to do. Unfortunately, it is not Medicare rebatable. The approximate cost for the screening for the 3 common genes is about $400. It will get Medicare rebated, but watch this space. So I thought I'd just also touch on health insurance. Look, one thing I would recommend, have your private health insurance and get covered before you conceive, because there are waiting periods. And the waiting period is longer than the period of conception. So if you get pregnant and then, oh, I haven't got my health insurance, I'll just join now, it's too late. So you've got to have coverage before you're pregnant. And look, even if you don't plan on using it, you plan on going through the public sector, have it there as a backstop. Because if you want to self-insure yourself because you don't have private health insurance through the private sector and even through the public sector as a private patient, it really does become quite expensive. But look, I suppose I'm pushing, and I've got an interest here because I pretty well just do private obstetrics and private gynecology, but the benefits I see is you get continuity of care. You see the one specialist throughout your whole pregnancy, at your delivery, and at your postnatal visit. Look, occasionally you'll take holidays or a weekend off, but you do tend to get continuity of care. In the public sector, you tend to see a different midwife or a different resident or a different registrar, different times, and you do lack some of that continuity. You also get patient autonomy. And what I mean by that is, look, I'll have patients that rock in and go, you know what, look, I think I'll just have an elective Caesar. I really do not want to have a vaginal birth. I've had friends that have had traumatic deliveries. I think I'll just have an elective Caesar. Now, it's very hard to push that in the public sector. You'll probably be talked out of it and pushed down the vaginal birth route, even if you really don't want to do that. While in the private sector, from my point of view, if a patient's informed that that's what they want to do, we try to give the patient what they want, as long as it's healthy for themselves and their child. You'll be delivered by a specialist obstetrician. So if you do need to have a caesarean section, or if you do need a difficult delivery, or if you do need suturing, it's done by a specialist. If you require an epidural in labour, or it's a spinal for a Caesar, it'll be a consultant anaesthetist, and you'll have a consultant paediatrician to look after your baby in hospital, rather than a trainee hospital registrar who might have done 1 or 2 Caesars and they're practising you with their 3rd one. So you've got people that have got a vast amount more experience than in the public sector. And probably the final thing to think about is the facilities. And I know Stephanie's going to talk much more about this, but certainly here at Northshore Private Hospital, the birthing suites are beautiful. They're big. The operating theatres run to time. They don't get bumped. And the postnatal areas are great. There's plenty of room for partners to stay. Pretty well all the rooms, apart from some Caesar recovery beds, have all got double beds, and there's lots of parenting suites here. So the facilities generally are nicer as well. So health insurance, even if you don't plan on using it, good to have a backstop, because with pregnancy, you never know what's going to happen. That's my talk. I haven't made it exhaustive. Look, I think one thing to think about, every couple is individual, and this is just trying to give you a little bit of a general overview. Everyone has different sort of thoughts, has different histories, everyone has different medical issues. So if you're not sure, touch base with your GP or get a referral to someone like myself before you are in fact pregnant. If you've got concerns, tick the box and then you're good to go. But yeah, as I said, don't leave it too late, because the clock does tick when you get into your late 30s and early 40s.
Thank you, Michael.
Any questions, Wendy?
I've got a couple. There's a few diet-related ones. We might not answer every single one now. We can always answer some of those later.
Yep.
One here, would you recommend doing regular blood tests during pregnancy to check iron, folic and vitamin D?
Look, what I tend to do is I check your ferritin or your iron stores early in the pregnancy, and most women, they're okay. I check it again when they do their diabetes screen at 26 to 28 weeks. And in my experience, about 50% of women, even if they're on a supplement with iron in it, are iron deficient at that stage of pregnancy. So then they'll have to start the bigger guns like Ferrograd C, which often play havoc with your tummy. And look, some women just don't tolerate that at all, and we'll give them an iron infusion during the pregnancy. So I don't think you need to do it every month or every 6 weeks. Those blood tests are more for women who are on thyroid medication. You really got to keep the levels properly. But iron, I usually check at the beginning and check again as you're entering the 3rd trimester.
Okay, thanks, Michael. Are fibroids dangerous, and will they affect baby movement?
Same again, look, there are fibroids, and fibroids are pretty common in women. Probably about 30% of women will have evidence of fibroids. And if they're quite small, they're not going to have any real impact on the pregnancy. They'll probably get a little bit bigger during the pregnancy, but probably not impact on mode of delivery or pregnancy outcome. Now, obviously, if you've got a really big fibroid sitting right down deep in your pelvis, 2 things can happen. It'll get bigger and it may obstruct labour for the baby delivering vaginally. And other things fibroids tend to do, as they get bigger during pregnancy, they can sometimes undergo a condition called degeneration, where they just outstrip their blood supply, and a woman will get quite acute pain, usually sort of later in the 2nd trimester, around the 18, 20-week mark. You can get quite a lot of pain from it. There's not a lot you can do about it. You would normally just treat them with analgesia. But my advice would be, if you've got fibroids, really resist the temptation to go getting them removed prior to getting pregnant, because it'll leave a defect in your uterus, which will you'll need to have an elective caesarean section. And the other thing is, sometimes if the particular surgeon's gone into the cavity or the internal layer of the uterus, the placenta can occasionally stick on that. And we do present cases here at our hospital when adverse outcomes have happened, and it's not uncommon where women have had previous surgery for fibroid removal and they've come to grief. So yes, fibroids can be an issue. It really depends on how big they are and the location. But my sort of thoughts on them are, try to not get them removed or sorted until you've completed childbearing.
Okay, one more quick question and we might go on to our next speaker. What are the symptoms of listeria? How do you know if you've got it?
Yes. Look, the good thing is listeriosis is pretty rare. It's a bad gastro, so you'll get nausea, vomiting, diarrhea, but not just that. You'll get a fever, you'll get muscle aches and pains. So you won't just get diarrhea, vomiting, feel pretty good, and you're over and done within 6 to 12 hours, which is probably what you'd get with a viral gastro. Listeriosis, you are unwell with it. So the only way to diagnose is to do a blood test or a specialised culture on the faeces. Look, if there's a really high index of suspicion, if someone's gone out and eaten soft cheese or raw eggs or something like that and you're worried about it, while you're awaiting the result, you can be put on amoxicillin, which is a safe antibiotic during pregnancy. It's quite effective for listeriosis until you get a culture back. But generally, it's a bad gastro, but there are other symptoms like muscle aches and pains, fever. You're pretty unwell with it.
Okay. Thanks,
Pretty
Michael.
rare.
We might leave you there. If we've got time for any questions at the end, we can ask you then. There's a few more questions coming.
I'm going to hang around.
We'll keep it moving. So we'll stop your sharing screen, and Chris, you're on. If you could unmute yourself, Chris.
Hi, and welcome to our talk tonight. And once you're pregnant and you get through those early weeks and you feel more reassured about pregnancy, you start to wonder about, what do I need to bring the baby home? And that's what I thought we'd talk about for a little while tonight, because it can be very overwhelming out there when you wonder about how much you need. Now, if you're the friend at the end of all your friends having babies, they will give you lots and lots of their hand-me-downs. And how do you know what it is that you actually need? So we do have a nice list that we'll send out to you at the end of this night for you, but we're going to go through the basics. So I think the first thing is, when do I need to be ready? So do I leave it to the end and buy everything, or do I just slowly through the pregnancy? And I think you need to be ready for babies by 36 weeks. So it's not uncommon for babies to come early and to be able to go home. So you want to be ready by 36 weeks. And then you need to think about your budget. So how much are we budgeting? And trust me, babies don't need a lot, but there's a few things that if you had some money and you were going to put it into your baby needs, then you could really get all of your children, such as the pram, the car seat and the cot. They're the big expense things that you're looking at that are going to take you right through all of the children. that you intend to have. So we start to look at this list. So I start with the pram. So that's the one that everyone wants to go out and buy. They've seen their friends pushing their prams. They're looking at prams. They've probably looked at prams before you've even fallen pregnant. But you really need to consider a few things. And the first one is weight. Some of the prams can be very weighty. So you've got to look at your car and what you're going to fit into the boot. And it's a good idea to maybe go to one of those big outlets where there's lots of baby things and ask them if you can take it out and see if it fits into your car. So I stood in a baby store and counted the prams, and there were 62 prams on the floor. So you can get really overwhelmed with how much is out there, and you really need to think about how you're going to use it. You're probably going to use a pram for about 2 to 2.5 years. It's not uncommon to go through 2 prams in that time frame. And you need to look at the facts of, am I a walker? Or am I really a person who just jumps in the car and goes places? Do I need my baby to sleep in this? Or am I generally going to be home? So there's lots of different factors about how this pram's going to work. And one of them that I try and get you to imagine is, can I get that pram basically into the car with maybe a crying child attached to me? So really think about this pram that you're going to use, because it's going to last you a long time. So the next big one is the car seat, and you probably need your car seat fitted in your car somewhere around the 36-week mark so that you're ready to bring baby home. And then again, when you go out into the car seat aisles, there was on average about 30 different car seats. So I really go back and do a little bit of research about the latest car seats out and the latest standards. And you have a choice between car seats and capsules. So capsules are usually quite mobile. You can have it in the house, you can take it out to the car, you can click it into a pram base. Now, for some people that works really well, especially if you've got stairs that you might need to go up and down with, whereas others prefer the car seat. They might be able to drive their car up to their front door and just put their baby in and out of that car seat. And both have merits. So I think spending a bit of time on that and really thinking about what might work for you in the end will probably be the right thing for you at that time. This is the only area where they don't recommend secondhand car seats. They really recommend you to go out and buy a car seat. And there are very good car seats at lots of different price points. So I don't think you need to spend the most expensive, but you need to get the safest that you can afford at the time. So the third big thing is the cot. So in this case, borrowing a cot is not necessarily a bad idea. So you might have had your sister who's now not using her cot and she wants to lend it through and send it through to you. But what I would recommend is a firm fitted mattress to the cot. So she might have had that cot for a few years. Mattresses have changed. For safety and safe sleep practices with the baby, you need that cot mattress to fit the cot. And children often, vomit in their bed, and when they get older, they even wet into their bed. So I would always buy a new mattress for that cot. But often the cot is fine, but it is something that's going to last you. If you had 3 children, it's going to last you about 6, 7, 8, 9 years. So it's really worth thinking about the height of it and how accessible it is to get the baby in and out. Cots come in 3 different heights now, and about 3 different sizes. So you need to look at the space that you have that you're going to put this baby in. So they're the really big ticket items that you need there. Then the most asked question I get is, how much clothing do I need? Because you could go on for clothing in a long, long way and you end up with tubs and tubs of your friend's clothing. So for the very basics, you're going to use the number 6. So we have 6 little singlets or bodysuits, depending on the season of the baby. Then we have 6 little outfits that go over the top of that. So in the winter babies, that would be 6 little long sleeve and little long sleeve onesies that have the feet into them. So we're having 6 in each of the sizes. So often there's the newborn size, then there's the 0 to 3 month size, and then they'll go up in sizes and ages across that year. So I would start with just the newborn, and the 0 to 3 months, because people will give you a lot of clothing. Now, if we've got our winter babies, they're going to need some cardigans and some hats for when they go out as well. Then a lot of people talk to me about how they wrap a baby. So this is probably the most confusing. So when you go out into babyland, you get aisles and aisles of wraps and swaddles. And parents are often overwhelmed as to whether they're using wraps or swaddles or sleeping bags. So you actually need a little bit of everything. Often when a baby's born, we wrap the baby. That's like a piece of muslin or a piece of jersey, and we're wrapping the baby. And this is to calm the baby and quieten their body movements. It's to keep them warm, and it's also to lengthen their sleep. So in that very newborn baby, we're going to wrap our baby. But as that baby matures, they can calm themselves in around the 10-week to 12-week mark. And then lots of people will choose to use a swaddle. So this is something that might be shaped and has a zip or it has Velcro on it. So we start using those somewhere around that 10 weeks to 12-week mark. And that will still still the baby's body, but allow the leg movement as that baby can get more control of their body. Once the baby is rolling, so physically rolling from back to front, then we free the baby's arms and we put them into a sleeping bag. So that commonly happens at around 4 to 5 months of age. And so across that very early 6 months of bringing the baby home, you will need a mix of these types of wraps, swaddles and sleeping bags to put your baby in. So that's the outer layer that's going to go on your baby. Then they ask about air temperature. How do I know that the baby's comfortable in the room that I'm going to put the baby in? So usually in the winter and the summer, we use the same air temperature, which is about 21 degrees. So we're either cooling our baby down in the summer or we're warming our baby up in the winter. So if the air temperature is around that ambient 21, 22 degrees, and I'm a winter baby, I'll have my singlet on, I'll have my onesie on, I'll be wrapped, and then I'll have a light blanket on, and that baby should be nice and warm and cozy. In the winter, the bassinet's going to keep that baby calmer and warmer because it's a smaller environment. Whereas in the summer, some people will choose to put their baby into a cot. And they'll choose to keep their baby close to them. So sometimes it's the amount of space. So the bassinet fits in the room for longer than maybe what a cot might fit in the room for you. So once we get down to these basics, it's good to make a list and just tick them off and buy them just one at a time, just building up the nursery that you want to have for your baby. Then there's a lot of basics that we have. So the creams, the nappies, and people often buy lots of newborn nappies. So a newborn baby probably goes between 8 and 10 nappies a day in that very newborn stage, where there's a lot of output from the baby. But that calms down and slows down, and they don't go through as many nappies as they get older. So usually only 2 boxes of newborn nappies, and then you can see the size of your baby. So if you've given birth to a nice big 4-kilo baby, he's not going to last as long as in those newborn nappies as maybe a little 3-kilo baby who's going to last a lot longer in those nappies. So don't go overboard, just the nappies, just a couple of boxes, and then see how you can go from there. So if we start from the nappy, we're going to need some wipes to keep our baby clean. Some people choose to just use some cotton wipes that they put in water. Other people will choose to use the wipes that you can buy across most of the baby shops. So we've got some wipes. We might need a few creams. Sometimes a barrier cream with zinc in it's good, and something as basic as a pawpaw cream would also be helpful. And then from there, building up the clothing that you need. People will give you a lot of clothing. So when it doesn't look like much, it'll feel like a lot once that baby's born. So we've got all these little basics. Remember the other big thing that you're going to be doing with the baby is bathing the baby. And so, you know, you could borrow someone's baby bath and you're going to use it for a really short period. By about 3 to 4 months, they're usually out of a baby bath. And so it's only a short period. You could borrow that one. Remember think about where you're going to use it. So you need a nice high space. So the kitchen bench is usually a good place to bath a baby. So we need a bath, a couple of towels and face washes. So we've got that set aside for the baby. It's not going to go into the household towels. They're just set aside for the baby. So across the next couple of months, you're going to just buy them as they come, or maybe people will give you things. So on the maybe list could be things like the carriers, the baby slings and the baby carriers, and they are now out there so that we can put newborns right through to 1-year-olds in them. So really go and try them out, and that's a good one that might go on the list for the baby shower, is a baby carrier. Things like baby bouncers and play mats and mats, they're going to be used a little bit further down the track. They're useful, but they could be given on the gift list as well. So the list that we will send out for you tonight will be the basic baby list that you can just sit and check through and make sure that you've got those basics ready by the time the baby comes at around having it ready around the 36-week mark, so it's ready for when the baby comes. Any questions?
I can't see any questions specifically for you, Chris, but feel free to use the chat, anyone, if you've got some questions. I do have some other questions, but we might let Steph talk for a minute and then we can answer some more questions. So if you think of any along the way, please feel free to ask, guys. It just muted us. There we go.
I'm the clinical manager of maternity, and I'm fortunate to have been here, like Dr. Vandergren and Chris, for 22 years since our hospital opened. We're very, very proud of our maternity unit here at Northshore Private. We have an awesome team of obstetricians, midwives, neonatal nurses, lactation consultants who work very closely together and support each other every day. We last year renovated our maternity unit, and we actually now believe that it would be one of the most spectacular maternity units in Sydney, offering 30 double beds, which has changed our approach. We are encouraging you as a family to have your partners stay and be on that journey to parenthood together where possible. We offer lots of antenatal classes as well as classes in the postnatal period. So you're never left alone. There's lots of education along the way as well. If you choose to come to Northshore Private, we would encourage booking into the hospital as early as possible. Nobody misses out, but we would encourage you to book in online so that we can start providing you with the information that's required for that along your journey of pregnancy. Before you book in online, though, you do actually need to book an obstetrician first. And there's a list of our accredited obstetricians on our website. At that point, I'd like to refer many of you to our website, where there is a virtual tour of our maternity unit, of our birthing suites and the postnatal ward, which is fantastic. Most information can be found there, but I'm happy to be contacted if there's any questions as well.
Thanks, Chris. Feel free to ask any questions about our maternity services while we've got Steph and Dr. Vandergren and Chris. I'll just check through here. Question for you, Chris. How much clothes for my baby should I bring in my hospital bag, and what should I bring for the baby? Just unmute yourself, Chris. Chris, you've got to unmute. You run around and tell us. We're just going to run around and ask Chris to unmute herself because she hasn't done that, so we haven't heard that answer. Maybe in the meantime, I might ask Michael a question. I'm in the early stages of pregnancy, but due to my miscarriage history, I'm very worried. Can I also see an obstetrician during my early days, or is it only possible when I'm 10 weeks pregnant?
No, look, I think in those cases, I always would recommend an early scan for those women, probably between 6 and 7 weeks, and I'll probably see them a week or two after that. So I tend to see them earlier. You scan them more regularly, just for reassurance more than anything else. So no, and I think whether it's me or whether it's your own obstetrician, tell the secretary, look, I've had a bad history, I'm anxious, I need a scan, can I be seen earlier? And most of us are really quite accommodating to that. So reassurance is the name of the game. So yeah, no problem.
Thanks, Michael. Just one more question. With a history of miscarriage and now again pregnant with just 4 weeks, is it normal to have some very light spotting?
Yeah, I think when you've had a history of miscarriage, any spotting's a worry, but it's not uncommon to get some implantation bleed around the time of your period. The problem is when you're only 4 or even only 5 weeks pregnant, it's very hard to determine viability of the pregnancy by sending you off for an early scan. So you don't want to be scanned earlier than probably 6.5 weeks because you won't see anything. So spotting's not uncommon. If it's concerning you, the only real way of checking viability at that early stage is getting pregnancy hormone level checked and then getting it checked about 3 to 4 days later just to see that it's rising at a reasonable rate.
Thanks, Michael. Chris, do you want to try and answer that question now? We've got you off mute.
So here in the hospital, we provide everything for the baby. So once you're here in the hospital, we have little gowns and singlets to put on the baby. So you only need to bring into the hospital a set of clothing to take the baby home. So a singlet, an all-in-one suit, and maybe a wrap, and if it's winter, maybe a hat till you get out to the car is all that's needed. But we do have lots of people who bring their own clothes in and dress their babies up every day, and that's perfectly fine as well.
Sorry, another question. Can you get a second-hand capsule?
No, they actually, even for people who can't afford a car seat or capsule, the places like Smith Family will give you a new one. So the thing they really highly recommend is that the baby goes into a new car seat in that family. So you can certainly use a car seat from child to child, but they don't recommend you buying a second-hand one or using one that's probably more than 5 years old because the safety rating on the car seats change.
Okay, thanks, Chris. A question for you, Steph. When is a good time to book if I start trying in June?
We'd recommend booking in the first trimester. As I mentioned earlier, you obviously need to book with an obstetrician and then book in online for the hospital. We don't get booked out, so don't panic if you don't book in too soon, but we do recommend that you book in that first trimester.
Okay, another question for you, Steph. Do you foresee live tours of the hospital being available in the near future?
Look, we're not offering them at the moment, and it's whilst we're guided by the restriction of people coming through the maternity unit. As I did say, our virtual tour on our website is very factual of what the rooms look like and what our birthing suite's like. And we are working on that often, and we'll be updating it as things change as well.
We've got a new video on the way, so watch this space. Keep on looking out on the website, but we'll advertise it on our socials. Another question, I'm still working. When is the best time or how many weeks before my due date should I stop working or take leave? That's a question for you, Michael.
Look, I think it depends on what sort of work you're doing. If it's office clerical work, you want a few weeks off before you have the baby. And look, in my experience, you tend to hit the wall at the 34 to 36 week mark where you're big, you're uncomfortable and you're not sleeping particularly well. And don't forget, some babies come 2 weeks early. So you don't want to work to 37 weeks and have 2 days off before the baby's born. I think if your job is quite strenuous with really long hours and you're struggling, you've got to call it quits earlier. And it also depends on your pregnancy. If you've got a twin pregnancy or a high-risk pregnancy, same again, you'd want to stop sooner. So I'd say around the 36-week mark's a good endpoint. 34 weeks is reasonable too. If you've got a high-risk pregnancy, you'll have to wind it back even more so.
Okay, thanks, Michael. Question for you, Chris. How do we manage the baby room to stay clean and not humid? And would it be all right if I put a bookcase in the baby room?
I think so. As long as it's generally as clean as you would keep your house, the room will be absolutely fine. So it's okay to put a bookcase in there and books in there, and you would clean the room the same way you would clean your general house.
Okay, thanks, Chris. Question for you, Michael. I had a scan at 13 weeks and got told I'm at high risk of preeclampsia and have been put on 150 milligrams of aspirin. Do you have any more information on preeclampsia?
Yeah, look, I'm not 100% convinced on that model of risk of preeclampsia. There has been a few studies saying that if women are commenced on low-dose aspirin, and I sometimes put them on a bit more calcium as well, you reduce your incidence of preeclampsia from high risk, whatever it may be in your particular case, by about 30%, but it's not a guarantee you won't get it. Look, preeclampsia is just one of those diseases that you can't always predict. If you've got a strong family history of cardiovascular disease, or if you start your pregnancy with slightly higher than normal blood pressure, and it being your first pregnancy, you're a little bit more high risk for it. But generally speaking, it tends to happen later in pregnancies. That's why the visits get more frequently after 28 weeks and they go to weekly after 36. So stay on the aspirin, it's completely safe. It will probably help and it certainly won't do any harm. And just monitor your blood pressure throughout your pregnancy as you would normally do. If you are feeling unwell in between visits, headachy, visual disturbances, a lot of swelling, get your blood pressure checked even in between visits with your obstetrician.
Okay, thank you, Michael. Maybe this one's for you, Steph. How much support do your midwives and lactation consultants offer once you've given birth?
So once you've had your baby, you come to the postnatal ward where for a vaginal delivery, you stay for 4 nights. For cesarean, you're there for 5 nights, which is an amazing time where you are given a lot of postnatal support in breastfeeding, settling your baby, preparation for going home. And we have lactation consultants rostered every day on the ward. So in your stay there, the midwife looking after you, if she feels that you need to be referred on to the lactation specialist, she will do that, or you can just request the lactation specialist see you.
And we also have some support after going home, don't we, Steph?
Yes, so we do offer an outpatient clinic. It's called the Helping Hands Support Service, and that's run 4 days a week. Chris is there 2 days a week with her expertise on sleep and settling, baby rhythms, and we have a lactation consultant there 2 days a week as well. So that's an outpatient service where you can bring your babies up to anywhere between from birth to a year.
Great, thank you. Another question for Michael. I have an underactive thyroid which requires no medication. However, I have been advised during pregnancy I will need medication to treat this. What effect does an underactive thyroid make to myself and the baby?
So if it's underactive before you're pregnant, profoundly underactive, which doesn't sound like it to me, it might affect ovulation. So you might find it a little bit more difficult to get pregnant. You might find that even if it's only borderline underactive when you start pregnancy, because of increased metabolism, your blood volumes increased, it might become more underactive as the pregnancy progresses. So if it's profoundly underactive, it can have some impact on neurological development in the baby. So you really do want to keep an eye on it. So for someone like yourself, I would get it checked pretty early in the pregnancy, even if you're only 6 weeks, see what the numbers are and check it every 4 to 6 weeks to see that you're not getting to the point where you really do need medication. It's sometimes better to be on a low dose of thyroxine than to be constantly worried about an underactive thyroid. And more often than not, when you've had the baby, it will probably go back to pre-pregnancy levels. So monitor it regularly. You might find you need medication once the pregnancy advances.
Okay, another question here for I think it's for you, Michael. Any tips and consideration when choosing an obstetrician?
Look, I think it's just an individual choice. You've got, I think, 38 different obstetricians here at the hospital. You've got male, female, you've got young, older, more experienced people. It really comes down to personal preference, experience. Look, all I can say, a lot of patients that I see, it's often recommendations from friends, from family, from previous experiences, not necessarily from your GP, because they're often the second port of call. You'll ask your friends, oh, who did you go and see? Were they any good? But look, the good thing is at Northshore Private, all of the VMOs are accredited. We have good quality assurance, and I think it just comes down to individual choice. And look, I will see some patients myself who say, look, I just want to let you know, I'm just, you're number 2 or 3 on my list. I'm just getting a feel for how you run things. And some people will shop around early in the pregnancy. It's a little bit expensive because you've got to see 2 or 3 different obstetricians, but it just comes down to personal preference. But the good thing is, look, all of the obstetricians here are well accredited.
Thanks, Michael. Another question for you. Is there a guide as to how much weight gain per trimester or week is healthy?
Oh, look.
Okay, I found this on the web for is there a guide just how much weight gain.
Siri's going to help. Siri's going to help. No, look, I don't weigh my pregnant ladies because there's so much variation in pregnancy. You'll see some women at the end of their first trimester, they've dropped 2 to 3 kilos because all they're doing is vomiting. They are so sick with morning sickness. And other women counteract that by just grazing on carbs to keep the nausea at bay, and they've put on 5 kilos. So weight gain is so variable throughout the pregnancy, but a healthy weight gain would be anywhere between 10 to 15 kilos for the duration of the pregnancy. Most of that you will have probably put on by about 30, 32 weeks, because towards the end of the pregnancy, you're quite big, you're quite uncomfortable, you've got reflux, you really can't eat a lot. So 10 to 14 is a pretty healthy weight gain, but look, my 2 extremes, I had one poor woman who put on 36 kilos. I think she had the Mediterranean philosophy of eating for 2. Her baby only weighed 3.1 kilos. And I had another girl who was so sick throughout her pregnancy. By the end, she was still half a kilo lighter than when she started. And she also had a 3.1 kilo baby. So your weight gain in pregnancy is a really poor correlator with how the baby's going. So just eat healthy. If you do put on a bit of weight because you're craving carbs and you're feeling really sick, don't stress about it. But yeah, 10 to 14, 10 to 15 is my sort of go-to range.
Another question for you, Michael. When do we share our birth plan with the hospital midwives?
Look, patients will normally give them to me, and if it is quite expansive, I will get a copy sent down to their notes so it's in their file before you even hit the hospital, or bring it in. But the first thing you want to tell the midwives who are looking after you, just, look, here's my plan or here's my preferences, so they know where you're coming from. Look, my advice is be flexible, have preferences, because plans, it's almost like you're building a house. There's always going to be variations. Things are going to go wrong. You want to be flexible. Have a fallback plan so that you're not putting too much pressure on yourself or your partner to have the perfect birth, because, look, babies get stuck sometimes. Babies get stressed in labour. Be flexible, but the midwives will know about you. You'll bring it in, or we'll often send a copy down to your file so it's there before you even hit the hospital.
Okay, thanks, Michael. I think we've got time for a couple more questions. So one for you, Chris. Could a newborn sleep in a normal cot?
Yes, they can sleep in a normal cot. And following the safe sleeping practices, we still put that little newborn to the bottom of the cot and then put a blanket over him, depending on seasonal. But yes, of course, they can start off in a cot. It's just smaller and warmer in a bassinet.
Thanks, Chris. I think some of these we've answered. I'm just scrolling through some of these questions. Question again for Michael. We've got quite a few dietary questions. I find MSG is in a lot of foods and plenty of sites advise against it. What's your take?
Yeah, look, I think try to avoid MSG if you can. You just want to try to avoid a lot of salt in pregnancy in general. But I think try to avoid highly processed foods. I think that's good and healthy living anyway, but even more so when you're pregnant. So if you're going to a place that has a lot of MSG, avoid it. There's lots of places out there that don't cook with MSG anyway. So yeah, I'm with you. Try to avoid it or keep it to a minimum.
Okay, thanks, Michael. And we might ask, this one's for Steph. I booked my delivery at Northshore Private. I'm 16 weeks now. What's next?
Congratulations. So you would have booked online, got a confirmation email. What you hear next is that about 20 weeks, you will receive an email from our customer service, Amy, where she talks about a few things, processes from there, where we will be booking to your antenatal classes. It will be inviting you and encouraging you to attend the emotional wellbeing program, which I failed to talk about earlier. We are in partnership with the Gidget Foundation and support the emotional wellbeing of pregnant women and women that are in the postnatal period. So we invite you to fill that survey out at that time as well. and we keep in touch with you, with our customer service along the way. So the next time, as we said, is at about the 20-week mark, where you'll get another welcome email from Amy.
Okay, thank you, Steph. I think we might have time for, do we have time for one more? Chris, where can you get a Bassinet mattress?
Oh, most big baby stores will have Bassinet mattresses, and then they can make sure you get the right size for the bassinet that you've chosen. So any big baby store will be able to give you one or get one.
Okay. One quick one for Michael. Michael, I have a pescatarian diet. Should I eat meat while I'm pregnant?
No, I don't think it's essential. I think as long as you're getting enough protein with your fish, that would be fine. It's not essential that you eat meat, as long as you're getting enough protein and iron in your diet. I think if you're a strict vegan, you really have to be a little bit cautious with, make sure you're getting iron and enough protein in your diet. But no, pescatarian's fine. You don't have to go meat eating just because you're pregnant.
Okay, thank you, Michael. And thank you, Chris. And thank you, Steph. We've hit the hour marker at 8 o'clock, so I think we might call it an evening. I can see there are a few questions there that we haven't answered, but we promise to answer those for you in the next few days via email. I'd like to thank everybody for coming along tonight, and we hope to see some of you at Northshore Private in the coming times. And thank you very much to everyone for joining our webinar tonight. If you missed part of it and you'd like to watch it again, look out on our socials, because we will be, we've recorded the session and it will be available soon. So we'll be in touch soon via email. Thanks, everybody.